internist by training and President and Chief Quality Officer of the Emory Healthcare Network. I'm sure you all have heard of that. The Emory Healthcare Network is a clinically integrated network that includes 2,000 providers, and of which 1,375 are employed faculty of the Emory Clinic. 150 are employed non-faculty and 475 are in private practice. Since 2011, the Emory Healthcare Network has served as the value-based care delivery platform within Emory's healthcare value-based contracts, which currently include 2 commercial payers and 3 Medicare Advantage payers. This is the world we're going to, so it's really great timing for Dr. Gitomer to be here. Prior to assuming the role with EHN, sorry about that, Dr. Gitomer was the Chief Quality Officer of Emory University Hospital Midtown, assumed the role in 2006 as Emory Healthcare embarked on its successful quality journey to achieve top 10 clinical quality performances, so yay us. The journey was successful when 2 of its hospitals, Emory University Hospital and EUHM, earned quality leadership awards for top 10 performance among academic medical centers from the University Health System Consortium. So with no further ado, Dr. Gitomer, thank you for being here, and we're really looking forward to it.
Do I need this? Do you want me to?
So that's for the
Oh, you're on the phone. No, it's okay. I'll carry it. Hi, people on the phone too. So first of all, thanks for having me come. And I guess the task is to sort of describe for you this sort of value-based world that we're entering. How many have maybe heard John Fox before he left, or other folks talk about World A and World B? Is that a familiar concept, sort of? Okay. So I live in World B. And so we'll sort of talk a little bit about that. So first thing is we'll talk a little bit about kind of why this whole value-based sort of payment model, sort of why they came into existence, what they're trying to address within our current healthcare system, and then talk about population management, which is what the network does, and sort of have you understand sort of what that is and what Emory's doing in response to that. And then just talk a little bit more detail about the Emory Healthcare Network. So let me just sort of set sort of a basic context for everybody. Back in 1999, the Institute of Medicine, so the Institute of Medicine advises Congress on health-related issues. So the Institute of Medicine came out with a report that said between 44,000 and 98,000 patients die every year due to preventable medical errors. Interestingly, there was just an article, a journal article that came out in the British Medical Journal this week, and it was actually I found out about it from the Washington Post. But anyway, they said that number is probably low, that it's probably close to about 245,000 patients die every year due to preventable medical errors, making it the 3rd highest cause of death. And then in 2001, the Institute of Medicine came out with another report, and what they said is, yes, it's true what we said back in 1999, but it's not because we have bad people. It's because the healthcare delivery system has flaws in it that we're incapable, really, of delivering the level of quality and safety that we want to deliver. And so for us to get better at that, we need to redesign the systems of care. In 2003, an article came out in the New England Journal from the RAND Corporation. The lead author was a lady named Elizabeth McGlynn. And what she said, what this article said was, they looked at between 7,000 and 8,000 patients, and they looked at 430-some interventions that patients ought to have, really mom and apple pie stuff, routine stuff that no one would disagree with. And out of that whole bucket of 400 and some services for those patients, they only received 55% of those interventions. Said another way, that article told us that if I was, as a patient in the U.S. healthcare system, the likelihood that I would receive all the care that I was supposed to receive based on that evidence was 2.5%. So just further evidence, there's unintentional harm that's happening to our patients. We believe it's because the systems of care are unable to really perform at the level that we expect, and that there are a lot of patients not getting all the care that we want them to have. And you all know that healthcare costs are going up. We experience that, either a bigger chunk out of our paycheck, or we experience it by higher copays. How many people here have chosen the high deductible health plan? Does anybody? Okay. So all of these types of strategies are basically making us pay more out of our wallets for health care. And to put some numbers around that, back in 2008, the average employed Georgian who had health insurance paid about 7% of their total compensation. Was it 8%? 7% of their total compensation for health care. Flash forward to 2014, they're spending 18%. So in effect, we got an 11% pay cut, all because of health care. And like I said, we experience that. We have greater out-of-pocket expenses. We're spending more than we used to spend for health care. So with that as a context now, I want to do one more level-setting thing. Back in the late 80s, early 90s, people sort of talk about our first attempt, at least in our lifetime, of healthcare reform. That was during the Clinton administration, the first Clinton administration. I meant his first, not, never mind. Anyway, and so managed care sort of really developed or blossomed back then. And what's important to understand as we look forward to what I'm going to talk about what's going on now, we have to understand the perspectives of all the different stakeholders in the healthcare system in their response to what was sort of the first foray into managed care, where the system was trying to get its arms around the cost of care. And so back then was really the blossoming of HMOs and a lot of the stuff that we're sort of used to now, but back then was new. So in response to that, first, we'll consider from the patient's perspective. Now understand, before that, insurance was indemnity insurance. And what that means is, and you guys probably know as well as I do, what that means is that basically the insurance would pretty much pay a fixed percentage of whatever the providers charged. So it was really easy to be the business office back then. You basically sent a bill, got a significant percentage from the insurance company, and then a very small percentage was attributable to the patient. Well, starting with the managed care and the advent of HMOs, now all of a sudden that the HMOs were now trying to get their arms around the cost, and they were putting in a lot of administrative requirements, to be delicate, hurdles, barriers to care. So now all of a sudden, before you could do a test, you had to do authorizations. Before you could order prescriptions, you had to do pre-authorizations. There were narrow networks. Now you couldn't just go to any provider. If you went to providers out of the network, either they didn't pay or they pay a much lower percentage. So it was a much more complexity. So from the patient's perspective, they lost choice compared to what they were used to, but also there was a lot of capitation for the providers, a fixed fee that the providers received based on the number of patients that they saw or that they were accountable for. And so as a result, because people knew about that capitation, there was a concern that the easiest way to save money was to deny necessary care. So there was a perception back then that patients weren't receiving all the care that they were supposed to receive. Now, we can debate whether that was true or not, but that was a perception, and so therefore it's reality when we think about going forward. And then there was obviously all the administrative burden I alluded to. From the provider's perspective, again, they felt the administrative burden, and then the providers back then were very unsophisticated in how they took on this flat fee, this capitation for payment, and they were basically signing bad deals. So there was a lot of financial risk and bad financial outcomes for providers back in the 80s and 90s who embarked on this. From the insurer's perspective, they liked it. If you notice, and you guys have probably seen this before, and I know it's small, but if you notice here, this is the U.S. cost of healthcare as a percentage of what they call GDP, which is the overall economic production of the country. And if you see here, there's this increase over time, but notice it flattened here. This is late 80s, early 90s when it flattened. So the insurance company liked this managed care because it made their finances much more predictable, and you'll see in a bit, as did the employers. But also they have to sell insurance to people. And if people were unhappy and that there was a perception that they weren't getting all the care that they needed, then insurance companies had trouble selling those products. From the employer's perspective, again, they like the idea of predictable finances, but they don't like unhappy employees, right? And then there's also this perception of necessary care withheld. So the only reason to bring this up is this. Remember, this is in people's minds. This has set people's perceptions now. So as we go forward into these new value-based arrangements, you'll see there's intentional thought and intentional interventions to address these specific concerns. So right now, what do people want? Well, patients want choice, right? They don't like these narrow networks. They want access, right? We all, and we as an organization struggle with that. And they want affordability. They don't like the 11% pay cut. When I say they, it's us, right? That's what we wouldn't want. And then the providers, we, as you guys know, you experience it every day. We suffer from this administrative burden, and we want relief from that. But we also want fair compensation for our services. From the insurer's perspective, they need affordable finances. They need a product that they can sell that's not too expensive. And it needs to be marketable from the perspective of access, quality, and cost, right? If you can't give the patients what they want, they're not going to buy your product. And for the most part, the employers are pretty much aligned with that. Okay, so that's what people want now. This is what they were experiencing when, you already went over what they were experiencing when they were dealing with managed care. So let's flash forward. So now we are, in the 21st century, right? And we know all these problems, right? Patients are being harmed unintentionally. Patients aren't getting all the care that we want them to get, and it's too expensive, okay? So now think about it for a second. You're a payer. You're CMS, you're Aetna, or you're a purchaser. You're UPS, or you're Emory, or you're somebody buying insurance, and you know of these problems. You know the unnecessary harm, or preventable harm, the problems with reliability of care and getting all the care we should, and the expense. So you're a purchaser or a payer. What can you do to impact that? What options do you have to try to address those issues? Yes. What can a payer do to us to make us do better on those problems that I outlined? It's how they pay, right? So the only lever, exactly, the only lever they have to pull, the only solution set they have to consider, the options they have are how they pay us. All right? So if you go from that perspective, when we go through the different payment models, that's why some of them seem so screwy. It's because what they're trying to do is address very precise problems with what ends up being a very blunt instrument, how they pay us. Okay? All right. So remember, the goals of payment now are we want to improve the reliability of care so patients get everything they should. We want to decrease the preventable harm, and we want something that's affordable. Okay. So fee for service. So fee for service sounds fair, right? I do something, you pay me. That's how we do everything else with what we do. So that's a good thing, right? Well, why is fee for service being challenged now? What things does fee for service drive? What are the things that are related to fee for service that are contributing to the problems that we've already talked about? Right. So you get paid for doing more, not necessarily doing what's necessary. Okay. So there's this, whether conscious or subconscious incentive to do more stuff. All right. What else? This stuff you may not be exposed to. So if you admit somebody to Emory Hospital and you put in a central line under their clavicle here, so that you can give them antibiotics and fluids and stuff, but you don't take it out right away when you don't need it anymore. And then the patient gets an infection from that line because those lines get infected. And that infection's so severe that the patient ends up in the ICU and perhaps even on a breathing machine, on a ventilator. We get paid more for that. So that was preventable harm. If we had taken out that catheter, the patient wouldn't have had those problems, but we get paid more. So fee-for-service also leaves for these really weird, perverse incentives, right? So it's going to diminish. We as an academic medical center, there will always be some fee-for-service because we have some really unique niche things that you just can't pay for any other way. But you know, your regular sort of health care, there's going to be some changes to the traditional I do a service and you pay me a flat fee. Okay? So does anybody know what pay for performance is? Okay. Pay for performance basically says we're going to pay you fee for service, but then we're going to also hold you accountable for some quality measures. And if you do well on these quality measures, then we'll give you a little more money. Now, as a primary care doc, I find that a little insulting. The implicit assumption there is if you pay me more, then I'll give you good care. Like, I'm not trying to give you good care now, right? The reason, remember what the Institute of Medicine said. The Institute of Medicine said, we know we're not delivering the care we want to deliver, but it's not because we're not trying hard enough. It's because our systems aren't designed well enough so that we can get the results that we want. So if you're going to give me a little bit of money to sort of do better quality, that's not going to help me. Having me try harder isn't going to be what's going to get us where we want to go. So while the spirit conceptually seems reasonable, hey, we'll pay some more for some more quality, it doesn't help us address what the fundamental problem is that we need to redesign the system of care. Does that make sense? Okay. Oops. All right, bundled payments. Does anybody know what that is? All right, so somebody want to say what it is?
It's when they bundle a procedure code into another one and say it's not unique, so they pay you one fee for that.
Right, and so that's how you guys see bundle payments at the moment. It's even broader than that. So right, so transplant's a great example, perfect example. So basically, you get paid a flat fee for a whole what they call episode of care of transplant. That'll include pre-transplant evaluation and testing and all that stuff, the transplant itself, the post-transplant care, and I believe, you can correct me if I'm wrong, I believe transplant ends up, for the most part, being a year at a time or something like that. So think about that now. So it's a flat fee for everything. So it's one fee for the surgeon, for the specialist, like the internal medicine specialist, for the anesthesiologist, for the hospital care, for if you need post-acute care. That's what these bundle payments are. It's for the whole episode of care. So transplant might be an example. Colon resection for a patient with a tumor, with a benign tumor, and it would include pre-op, intra-op stuff, post-op stuff, skilled nursing, some follow-up visits after that, one flat fee. So how is that different than pay for performance? Well, let me just say one thing first, and then we'll talk about that. And the way they come up with the fee is they say, here's the fee for the procedure, say colon resection or transplant, whatever. Here's the fee. But the insurance company knows when they add up all the costs that end up being related to the procedure, it's not just the cost for the fee, but it's all this other stuff, right? So there are these two costs. And then what they do is as we as providers, we negotiate with them something in between. And sort of conceptually, what we try to do is say, okay, if we get rid of that preventable harm, like that patient, having the line in too long, if we get rid of that preventable harm, the average cost isn't going to be up here, it's actually going to be down here. So if we can come up with something between that and what the fee is, then if we do well, then we can make a little money. The payer wins because they're not paying this, they're paying this. Does that make sense? So in other words, it starts to incentivize to get rid of the preventable harm. But it also, for us to do that, that means the anesthesiologist and the transplant surgeon and the nephrologist and the skilled nursing folks, we all have to get together and say, how are we going to do this? We need to redesign the care. That's what we said earlier. That's what the Institute of Medicine said, right? They said we have to change the systems of care. So for bundle payments around that episode of care, that's exactly what we're doing. So it starts to align the incentives in an appropriate way. Pretty cool. That's what we want, right? And then we can win because there's savings to the system. We benefit some from that savings. The purchaser benefits some from that savings. The patient benefits because they don't get the preventable harm. It's all good stuff. What's the one problem with bundle payments? The rest of it is fee for service. So we still have all the other inefficiencies down here for any other episode of care other than for what we get bundles for. But providers, because that starts to align the work, providers start to dip their toe in value-based payments by doing bundle payments because it's not very risky. Okay? But it starts to align and get you to do the work. Then we have till 2:30, right? Yeah, and I don't want to finish with time for questions. Okay, cool. Okay, shared savings. So shared savings was what we're doing right now with Blue Cross and Aetna. So what shared savings says is there's a population of patients for whom we are held accountable. And we don't need to get into how that's determined, but basically think about it as, you know, the patients that we do primary care for. So we're accountable for those patients, Blue Cross patients who see our PCPs. It's not exactly true, but for the sake of this discussion, that's good enough. And then it says, historically, that population of patients cost, you know, this much money. But we know with inflation and everything else, the actuaries can say, well, in 2014, they cost this much. In 2015, they cost this much. In 2016, we think they're going to cost this much. So then our actuaries and Blue Cross's actuaries or whomever, payers' actuaries, get together and debate and settle on what this number is, okay? Projecting forward what we think the number ought to be. We then get paid fee for service. And if our total at the end of the year is less than what they predicted, then they're dollars to share. And then there are some quality measures that then determine our performance on those, then determines what percentage of that shared savings we get to keep. Does that make sense? So think about it. Remember what we said we want out of this. We want reduced preventable harm. We want to increase the reliability of quality, and we want to decrease the cost of care. Taking accountability for a whole population of patients starts to do that. Okay, so that's what shared savings are. The problem with shared savings is that cost target over time, because it ends up being as we improve our performance, when you project forward from a lower number, right? So the cost curve gets bent. Our ability to then perform better than the cost target diminishes over time. Does that make sense? So therefore, it has a finite lifespan. We can only be successful in funding our infrastructure for a finite period of time with shared savings. So ultimately, what our goal is to get to capitation. And we said, wait a minute, capitation back in the 90s was bad news, right? People lost their shirts and all this stuff. Well, we've learned. Number one, we're more sophisticated. We won't sign these bad deals. Capitation back then had an incentive where you didn't want to take care of sick patients because they were going to be costly. Well, now, since we risk adjust those patients, we actually want those patients, because if we can coordinate their care and improve their care compared to what was projected, then there's actually money in there for us to save. If you're totally healthy, we can't improve on that because you're not going to spend any money anyway. So in the shared savings world, if you're totally healthy, that's not a great population of patients to try to get a return on. Does that make sense? You got to be sick for us to improve on, and sick and at risk for spending a lot of money, then we improve on that, we spend less money, and then we win. Right? So you can start to see there was never an incentive for us to do, other than we in our heart want to do the best for our patients, and we always want to do that, but there was never a financial incentive for us to think about that preventable harm. So that's what capitation is. And that's where we want to go, because now we benefit entirely from the savings, and that'll help us fund our infrastructure. And we're going to talk about what systems we need to put in place for us to be successful. And lastly, you guys may remember a couple years ago, Piedmont and Wellstar got together and had a health plan, and it's sort of fizzling out at the moment. But so they took on being a payer and a provider. We've chosen not to go down that path, because if we go down that path, you got to process claims, you got to have reserves in the bank in case you have a bad year, which is, 10, 20, 30, 40, 50 million dollars. So it's just, we're not equipped. That's not our business. So we would much rather take accountability for the health care of the patient rather than taking on all the responsibilities of a health plan. Now, we may do that down the road, and we'll have to figure out how to do that as we partner with other people, but that's just to show you the continuum. Now, remember what I said, the Institute of Medicine said we need to redesign care. Well, what's implicit in these payment models is that you necessarily have to redesign care at greater intensity as you go up the slope. So if we're going to just do pay for performance, I can try a little harder maybe, or have my office staff focus a little bit more on those few quality measures, and we can get better. But if we're going to take on capitation, we need to really transform the way we deliver care so that we can get that level of reliability. So it's that work that I talked about around bundle payments, right? Same kind of thing, but for everything. All right. So that's why. So, and to do that, you need infrastructure, you need IT, you need time for people, you need certain staff to do all this stuff. You need money, and so therefore you can't get up to these levels of performance without getting the payment models that align. Does that make sense? So, how many seen this slide before? Oh, not many. Okay, cool. John Fox must not have made his rounds over here. So this represents fee-for-service conceptually, that we think fee-for-service is, was pretty high for a long time, and we got really good at fee-for-service, by the way. But we believe over time fee-for-service is going to decline for all the reasons we talked about. And then, right now, or say maybe a couple years ago, accountable care, these value-based contracts, shared savings, bundle payments, all that stuff were pretty rare. We believe over time, for all the reasons we've said, that that's going to increase. And there are a whole lot of transitions that we have to do, like I showed you on that graph, that we have to do to be successful over here. That's an entirely different book of work than what it took to be successful here. And oh yeah, if you spend too much time doing this when you're back here, you can't afford it and you lose your shirt. So you have to time that leap from going from fee-for-service to value-based contracting. Does that make sense? Okay. And I'll show you what I mean by how the work's different and how they conflict. So that's where the whole concept of World A and World B comes from. World B is value-based, World A is fee-for-service. Pay for volume, pay for value. You may have heard that as well. Okay, so just to demonstrate how the country's going, is that these are this organization, Levitt Partners, a consulting group. They sort of make a business of counting ACOs across the country. And so right now there are, actually it's greater than that now because there's been some new enrollments since I made this slide, but there are probably around 500 or 520 Medicare related ACOs right now. And then there are more than, you see the number for the Medicaid ACOs. This is woefully undercounted. That is commercial ACOs, because you don't have to report. This you can get, out of the Federal Register and stuff. This you have to sort of go around and count around the country. But the point is, there are a ton of ACOs across the country now. So, and ACOs are purely put together to be able to participate in one of these value-based contracts, bundle payments, shared savings, capitation. Okay? And we'll talk a little bit more about those definitions in a minute. Okay. So, how do you decide what determines in a local market whether or not there are ACOs? So we know right now Emory's the same as any other employer. really, really struggling with healthcare costs. So we're putting a lot of pressure on, in our case, Aetna, to say, guys, you got to come up with something we can afford here. This isn't working. We're having to, give our employees pay cuts, relative pay cuts. We don't have the resources we need to do the stuff we want to do. We got to do something. So there's this enormous pressure on the insurance companies. Well, if you're an insurance company, you only have two choices. You can either work on the fees for each service, or called a unit cost. So how much is an MRI? How much is a DRG in the hospital, or whatever? What's the case rate in the hospital? How much is an office visit? Right? You can slog it out at the negotiating table about what's the cost of each individual unit. The problem with that is that's exactly what we've been doing all along. And so if we're going to continue doing the same thing over and over again, we're going to get the same results. So the other alternative is to go for lower total cost of care. So let me give you an example. We just got back some data from Aetna, from our accountable care contract, where they share data with us, where they looked at orthopedic procedures done by Emory. And as you guys may or may not know, our fees for, the surgical procedure, for the MRI or whatever, are some of the higher in the market, right? But our episode costs are 16% lower than the market. So what that means is our orthopedists have fewer readmissions, have fewer returns to the OR, have lower infection rates, and all of those things. So the total cost of care is lower, even though our unit costs are higher. Okay, so that's what I mean by lower total cost. But so insurance companies know how to do this, know how to negotiate that. We know how to negotiate it. They have systems that have been doing this for decades, right? It's the comfortable place to be unless you look forward and say, am I going to get a different outcome or not, right? If we go down here, it's a whole new world. So I go for most of the contracting at some point now, I go in with Allison or Patrick or somebody as we negotiate with the payers, because now this clinical component is really, really important. So if you're a payer and you want to engage in this, you got to have a provider that's willing to collaborate with you. And also, by the way, you need to be willing to collaborate with the provider, or they're not going to sit down at the table with you. All right, so it's sort of, cliche, it takes two, right, to do this. And if either the payer's not willing or the provider's not willing, ACOs don't happen in the commercial market. Okay. The other problem is all of their systems are set up to do the traditional, unit cost, fee-for-service type of reimbursement. They don't have standard systems now that know how to manage and collaborate around value-based contracts, bundle payment, shared savings, capitation. So we've run into that a lot. You guys may experience it to some degree, or at least the folks that are processing the payments and stuff. It's much more complicated, right? And so unless you're willing to take this on from a payer side, unless you've got somebody who's willing to collaborate, value-based contracting doesn't happen. So it's a pretty complex situation to decide, do we go down value-based contracting or not? John Fox, before he left, sort of set a vision. He saw, if you will, where we were going, and said we need to create a system and an infrastructure so that we can be successful in where I think we're going to be. Yes, we may take some small hits right now because of that, but we believe that you need time to develop that, and therefore we're going to start now so that we'll be ahead. And he really wanted to be first in the market to do this, and we were. This is just more sort of ACO stuff. The one thing I will tell you is in 2013, the ACOs, Medicare saved $383 million. And in 2014, they'd saved $465 million. They like this, right? It's not going to go away. Doesn't matter who wins in November, it's not going to go away. So there's one more thing. It's MACRA, or familiar to anybody here? Okay. So back in the 90s, there was legislation that the amount of payouts from Medicare the increase in the amount of payout from Medicare could not exceed the rate of inflation. Now, we've already showed you as that the percent of GDP, as that goes up, in effect, you're exceeding inflation there, right? And so, but what happened at the end of every year, Congress didn't have the appetite to legislate those fee cuts, and it never happened. But what they said was, we're not going to do it now. We're going to record how much this should have been, and we'll do it in future years. So it happened year after year after year after year after year, and then by the time that this actually ended, it was something like Medicare would have had to have a 23% cut in reimbursement if they were going to follow what the legislation said. So they finally did what they call the doc fix, or the SGR, Sustainable Growth Rate Repeal. So they got rid of that inflation adjustment, but said, and everyone cheered and was happy, But in the background, they said, but we still have this problem, cost quality. We read the Institute of Medicine reports because we commissioned them, right? So they said, we're going to change the payment model. And here's how we're going to do it. The providers have two choices, only two. If you're in fee-for-service Medicare, which everybody is, you can either go down a pay-for-performance track, or you can go down an alternative payment model, read value-based payment model, bundled payment, shared savings, capitation. That's it. Those are your two choices. And oh yeah, by the way, this pay-for-performance, 60% of your performance is based on cost and quality. So 60% is based on overall cost of care for Medicare beneficiary, and within that 60% is also the quality of care, stuff getting done. McGlynn article about 2.5%, right? So that's it. So basically what's happened is, aside from all of the ACO stuff that you saw that Medicare was doing, they basically said, we're going down the value-based payment model. And what's also implicit in the what's also suggested by the legislation is it's going to become more and more uncomfortable to not go down this path. They're going to make this more and more difficult to just do pay for performance. So it's very clear. Medicare has sent a very clear message. And for a sports analogy, the great hockey player doesn't play where the puck is, but plays where the puck's going to be. And so Medicare has been very clear now. The puck's going to be value-based payments. Okay. All right. So if you're going to be successful in value-based payments, how do you do that? And that was actually a challenge I had. So Patrick worked really hard for 2 years and got us a shared savings arrangement with Blue Cross that went live in January of 2014. And he said, I got your contract signed. I'm done. Have at it. So now we're tasked with, now I have to perform. I have to improve quality, not me personally. Our organization has to improve quality and reduce costs. So how are we going to do that? We do that by achieving population health. So what population health is basically is that you have a defined population of patients, and you basically improve their lot. You basically improve their outcomes of care for the individuals, and have no disparities amongst any of the population. Right? So that's the goal. The way we measure our progress to the goal is something called the triple aim. Anybody heard of the triple aim? Is that a familiar term to anybody? Okay. It's sort of a buzzword, but basically what the triple aim is, it's measurement around the experience of care, the overall health of the population, and the per capita, the per head cost of care for that population. So it's cost, quality, and experience of care. So that's how we measure the health of a population. How do you improve the measures, the AAA measures? You improve it by doing population management. So we want to achieve population health as measured by the triple aim by doing population management, which are a series of interventions and things that we do that impact the overall health of the population. Okay, so those are the definitions. You measure population health with triple aim, and you improve the health of the population with population management. Right. So how do we do this? You know, it's pretty daunting. So in the Blue Cross contract, we had about, I don't know, 30,000 lives when we started. So now we as an organization have to improve the quality of care, making sure the patients get all the stuff they're supposed to get, but also reduce the cost of care. How do we do that? Well, one thing we realize is not everyone needs the same stuff, right? Patients have different levels of need, and you can define that as levels of risk. And what we also know is that the top 5% of patients consume about 80% of the cost of care. So they need one type of intervention. Healthy people, they need to be engaged with us, so if they do get sick, they come to Emory, but also we do everything we can to keep them well by doing their pap smears and mammograms and colonoscopies and all the routine health maintenance stuff, okay? So these need very different types of interactions with us. So, you know, for the highest risk patients, we need to coordinate their care because their care is very complex. One of the things we said was we like those sick patients. Well, not like we don't wish that on anybody, but we have greatest opportunity for those sick patients because that's where we've dropped the most balls anyway. So if we coordinate care better for them, then we can make their lot in life better. For those that have acute and chronic conditions, we want to make sure they get all the care they're supposed to get. So we need to make sure that every diabetic gets everything they need and every patient with heart failure gets everything they need and depression, and you get the point. So there we focus on getting the right stuff done. And like I said, for the healthy patients, we basically need to engage them in and to have healthy lifestyles and to connect with us if they do need health care and to keep them well. So different strategies for different levels of risk of patients. So how are we going to, what are our strategies now to affect that model that we just described? So we start out with a population of patients and we identify, you know, we engage them with us, and that could be electronically, that could be a lot of different ways. We engage them and help them be healthy and well, but then it's not going to meet the needs of the entire population. A large group of patients have acute and chronic conditions that we need to address. So like I said earlier, the one way that we can address those patients who have acute and chronic conditions is make sure that all of our care plans get executed reliably. But in spite of that, we're going to fail. Any process we do is going to have some amount of failure. So for example, if everybody who comes in my office with diabetes needs an eye exam, a foot exam, and some blood tests, even in spite of our best efforts, a few are going to get through without it. But also, all those people that didn't come to the office, no-shows, whatever, we need to take care of them too because we're accountable for them. So the care plan failures, you know, are those patients where, in spite of our best effort, we didn't get everything done. But there's also a small group of patients, the top of the triangle, whose condition is so complex and whose overall health is they're so vulnerable that these care plans don't really meet all of their needs. And so they need some extra support. So what do we do with them? So for those vulnerable patients, we have a care coordination program where we give them more touches so that we make sure that they're doing well. And then for the care plan failures, we need a system that, number one, knows there are patients, knows what they're supposed to have, and allows us to reach out to get them, to bring them in. Okay, so that's our overall strategy for how we're going to address population health or do population management. And so basically back to the paradigm of the triangle, so the high-risk people are the complex ones we talked about. The rising risk, those people with acute and chronic conditions, are sort of spread out all through it. Excuse me. And then lastly, obviously, the healthy patients are in that big majority. So these are the interventions that we're doing to execute that. We have a care coordination program. We're creating primary care practices that are, you may have heard of medical homes. We're creating those. And then these are IT solutions to help us do this part over here. So remember what I said, if you're going to give me a little bit of pay for performance, I can't fund this, right? We need a payment model that I benefit from the saving, that we receive our share of the savings to the system, so that we can invest in all of this. So the care coordinator program, so excuse me. Imagine Mary Jo, average insured Georgian, so therefore not an average Georgian because she has insurance, but an average insured Georgian, and she gets admitted to the hospital, she gets discharged, and she's supposed to get all this stuff done. The reality is, and McGlynn told us this, that not all of it happens. She has her son's got to go to band camp. She can't afford all her prescriptions. She arbitrarily picks a couple she doesn't fill. There's some inefficiencies amongst the providers to take care of her. Long story short, Mary Jo ends up back in the hospital. Now, let me just ask you, just sort of raise a hand. Has anybody experienced this themselves or had a family member or a friend experience this? Usually more than that, but still a good number. This is the way our care coordination program works. When she gets discharged from the hospital, we actually have an electronic notification that comes out of the data warehouse that goes to our care coordinator program. And what our care coordinator does is then reaches out to Mary Jo, and because she's already knows her because we've identified her through prospective analytics, and then make sure she gets her meds right, identifies ahead of time that she's not going to be able to afford her medicines, works with the providers to get her a cheaper solution, and then exchanges information amongst the different consultants so that everything's more efficient. And in our cartoon ending here, she doesn't end up in the hospital. Okay, so that's how you eliminate preventable harm to these really complex patients. Not rocket science, but hard to do execution. Conceptually, it's very simple, right? So here's what happens. So we actually have ways of identifying who are these people that are complex. We use analytics that's based on billing data. If they've been in the hospital or the ED, or if a PCP just refers them into the program. And then our care coordinator screens them, risk stratifies them into those tiers like we talked about, creates a follow-up plan for them, and by doing that, we've actually shown in a cohort of 1,800 patients that we reduce hospitalization by ED use by 15 visits per month and hospitalizations by 7 admissions per month. So that's how you prevent preventable harm. For the medical home, let me just sort of flash forward to Mary Jo. She's coming in, so one small part of what we talked about before, she's coming into the PCP. That's her problem list. The PCP actually knew she was coming in, planned for her to come in, knew what she needed, knew who she was seeing, made sure they had all of the information. When she came there, their analytics program said she has all these conditions. Based on these conditions, she ought to have this list of stuff done, and it knows whether she's had it done or not. And for those things that haven't been done, the team can then get that stuff done. And then if she happens to slip out of the office without one of those things happening, we have an analytics tool that we review on a regular basis and identify, hey, she got out of the office without this happening, and we reach out to her to make sure it happens. Okay. It's called using a disease registry. So it's just conceptually, we plan before the visit, we're supported during the visit, and then we're supported after the visit in case the first two fail. So imagine practices that are doing both of those things, that are using the registry and are also doing some outreach to those high-risk patients. So that's a typical, conceptually, that's what a medical home does. But we could have a specialist work at a medical home, say an endocrinologist, working with a primary care practice and help them take care of a much more complex diabetic patient, so they have greater skills to sort of manage those patients because there are not enough endocrinologists. And so we've made that, we've now sort of increase the population of patients that the medical homes can take care of. But also, we will need referrals to specialists, and so you need to define those handoffs. How's the patient packaged when they come to see the cardiologist? What tests have been done? What things have been tried, right? And then there's two-way communication back and forth between primary care and specialists. I know you may say, doesn't this happen now? And the answer is no. And then also, specialists send it back to the PCP now, and you said, here, the patient is doing well, here's where they are. If they go outside of these guardrails, I want you to send them back. But in the meantime, to keep them in the guardrails, do this. Okay. So real high functioning two-way communication between the specialist and the PCP. You could also have a specialty medical home. So one of our medical homes is actually integrated memory care. If any of you guys have heard of that, it's a dementia medical home that they're doing within neurology. So that's a specialty medical home. And then you could also just put a PCP in the middle of a specialty practice. So we're thinking about doing that for transplant. Transplant's got all of these healthy post-transplant patients who are still connected to transplant more than a year after transplant, but they're not getting their mammograms, they're not getting their colonoscopies because transplant's focused on transplant stuff. So put a primary care doc in there to take care of the complete care. This part I don't need to go into a lot of detail. We've invested a lot in analytics and the electronic infrastructure for the network. Everyone's got to have an EMR. It's all connected together electronically. We can have two-way communication. It also populates that registry thing that we talked about earlier. So the last thing I want to talk about, you say, gee, all this seems primary care focused. You know, what's the role of the specialist? Well, let me show you something really cool. Actually, let me since we're running out of time and I want you to have questions, let me do this. So this is a surgery scorecard that Dr. Sweeney and his group put together. He calls it a value scorecard. And on the bottom is complication rate from a very reliable source called there's a national data registry. So that's complication rate, and that's cost of care. So if you're down here, you have low complication rate and you're less expensive. This is high value. If you're up here, you have a higher complication rate and you're more costly. Now some people are going to be up here. So we have surgeons at Emory that basically they're the only one in the region who do all these really complex abdominal surgeries, and there's no way to be efficient for them. And it's just they're going to be up here, and that's okay. That's the thing about data. This isn't to be punished. This isn't to punish anyone. It's just to give information. So those surgeons are up here. They're going to stay there. They can work on some little things to maybe try to improve things, but that's fine. But there are other surgeons up there. For example, there was a surgeon who was up there who did a bunch of different kinds of cases, but for this one didn't do a whole lot of these. And so what he decided was, gee, I don't do a whole lot of these. My colleague down here does a ton. I'm just going to refer all of those to him or her. All right. So this is value. This is how you assess value as a surgeon. But then they said, hey, gee, a common complication across all of our surgeons is wound infection. So what they did is they got a wound infection group together, and then what they did is they came up with a new care plan, reliable execution of care plans. Came up with a new care plan of what we do, you know, pre-op, intra-op, post-op, post-acute. When we do this, and then by doing that, what you see here is this red line is the expected complication rate based on this national surgery database. So see, we were doing worse than the country before, and then by implementing that wound infection stuff, you can see that we're now performing better than the rest of the country. So trying to do what we do, the stuff that we're supposed to do that efficiently, and the stuff we're not supposed to do, stop doing. Last thing real quick. We also have a Medicare Advantage strategy, Emory Healthcare Network Advantage. You may have heard it as Care More. Okay. Basically what it is that we have a sort of whole group that's working on this. There's a special doc in there that's called an extensivist, and what he does is he or she, we have both, sees patients in the hospital, skilled nursing, and the care center. But it's not to the exclusion of the PCP. It's actually in partnership with the PCP. But then within the care centers, and we have two of them, one in Stockbridge and one over here in Decatur, that there are nurse practitioners there that are executing 30 different clinical programs: diabetes, heart failure, depression, wound, anticoagulation, a bunch of those. And so then what happens is when a patient gets, so here's basically what happens. There's a bunch of Medicare enrollees, and then based on several different things, we risk stratify them. We do what we call a healthy start visit, which is a sort of a physical where we try to identify all their conditions, and then are they candidates for any clinical programs? If they've been in the hospital, we use a prospective analytics, or if a PCP refers them, and we risk stratify them. But then what happens is life happens and they become less stable. But we have these different tiers of resources now that we can devote to them, whether it be the extensivists in the hospital or in the skilled nursing facility, or whether it be in the care centers. And basically by implementing those interventions the infrastructure that we've created, it gets those patients back to their best level of stability. And what you see there on the left, on your right, is basically dramatically better outcomes than traditionally we see with Medicare. So we're executing that right now. So that was a very fast sort of journey through value, and happy to, I mean, I have time, but you guys been out, but happy to answer some questions if I can. Right. Right. We don't lose any of that. All the stuff, I mean, it was like I showed before that I'm going to need to use the specialist. What I want to do is make sure those handoffs are good. But no, absolutely, we you know, the special, that's what I was trying to show both in the medical home stuff, but also in that last bit. There's a lot of work for specialists to do here as well. Yeah. The CareMore or the one before it? I'll repeat it. So the question is, we're an academic medical center. We get a lot of the most complex. It really comes down to who are we compared to. So for the most part, we tend to use what used to be UHC. Now it's now called Vizient. So it's all academic medical centers across the country. There are about 110 of them. So we do compare ourselves to like organizations. But also within that database that I showed you, the NISQIP database where they captured the complication rate, that's risk adjusted, and it's not risk adjusted based on coding. It's actually risk adjusted based on nurses abstracting the chart in a very standardized way. So the point of that database, and to your point exactly, it's probably the best we have at really identifying the complexity of a patient and appropriately standardizing it for risk. All of it's imperfect. Your point's well taken. Just like I said, you know, we have surgeons that belong in the upper right because that's just what they got. But we also kind of rest on our laurels a little bit and saying that, and sometimes there's blocking and tackling that we don't do well. Yeah, it's fine. So the question is for macro, what are we going to do Mr. APM? So here's the complexity. To go APM, a defined percentage of your Medicare business has to come from the APM. And for an academic medical center, we have a lot of patients who are going to come in whose PCP, whose attribution is going to come from the outside. So we think for a lot of the specialists, we won't be able to meet the thresholds, so we may have to go down the MIPS path for them. We may have both too. And it's not clear if it's going to be at the NPI level or if it's going to be at the tax ID number. If it's at the tax ID level, we're stuck. Although we may also consider spinning off certain new tax IDs, something you guys will love, new tax IDs so that we can then have at least small cohorts within APMs. And the reason, for the rest of you, the reason we want to go down an APM path is there's a flat 5% bonus on top of anything you do within the APM. So like I said, they're really trying to push us towards the alternative payment model. But they also realize you have to build all this infrastructure before you can actually perform there. Any other questions, comments? Is this what you wanted? Good. Well, thank you all for having me. I really enjoyed it. This is very helpful.